Welcome. This is a lecture entitled Emergency Neurosurgical Procedures, What the Allied Healthcare Provider Needs to Go. My name is Michael Carsey, Assistant Neurosurgery Professor at the University of Michigan. These are my disclosures, which are not relevant to this talk. The outline of this talk is on these particular topics, assessment, and then running through the various neurosurgical emergencies, and a little bit of discussion about each of them. These are two references that were very helpful for this particular talk and can be a reference for learning more about these topics. So the first topic is about patient assessment and monitoring. The primary thing in a neurosurgical emergency is to assess whether a patient is in a comatose state and then get a good neurological exam. A coma results as a patient has an injury to the reticular activating system, extending from the thalamus to the brainstem, or having bilateral cortical injuries, which disrupt the thalamocortical or cortical fibers. What's really important for any patient presenting with altered mental status is to identify when they were last known normal, obtain a Glasgow coma scale, evaluate brainstem reflexes, and obtain a CT of the head along with all laboratory workups. Non-structural causes of coma and altered mental status can include drugs, hypoglycemia, renal and liver failure, sepsis. And one thing to note on the Glasgow coma scale here, I've drawn a red line which distinguishes between flexing and extending. That's thought to be an injury at the level of the red nucleus, which changes a patient from a decorticating to a decerebrating posturing position. And here are several examples of severe bilateral thalamic injury or cortical injury, which would result in a comatose state for a patient. A general workflow for identifying the next steps in a neurosurgical emergency are to start to use the history to delineate the next line of workup. So if a patient has a stroke that's suspected, the next step would be a CT, CTA, evaluation for hemorrhage, consideration of TPA and thrombolysis, and so on. So these various algorithms shown here for infection, one would do cultures and sepsis workup along with imaging. For seizure, evaluation for status with anti-epileptic medications and EEG. Headache that might precede a subarachnoid hemorrhage will be evaluated with a CT scan. And coma after cardiac shock would have elevated troponin levels and would initiate a treatment algorithm to help with brain protection. Traumatic injury would involve stabilization of the patient and imaging workup. Narcotic overdose would involve reversal, and unknown causes can start with the CT of the head to look for mass effect or edema, followed by MRI scan to help with identification of any subtle lesions not seen on a CT scan, and then consideration of EEG to look for a subclinical seizure event. Brain monitoring is very important for patient to be able to ensure that there's adequate cerebral blood flow. Intracranial pressure, or ICP, basically measures the pressure inside the cranial vault, which is a fixed space. And during traumatic brain injury, ICP autoregulation is lost, and one can have decreased cerebral blood flow. So one way to look at this is to evaluate cerebral perfusion pressure, which is the difference between mean arterial blood pressure and ICP. And you can see on this graph a normal graph showing what autoregulation looks like, the thickened curve, whereas a disrupted curve looks like the thinner line, which does not stabilize blood flow more regularly across a larger range of blood pressures. One can see as you increase blood volume within the brain, there's an exponential increase in intracranial pressure. The brain vault really cannot accommodate a significant additional volume, especially when acute. So generally when patients have a GCS less than 8 and we're considering intubation, we also consider placement of intracranial pressure monitor. These are examples of pressure monitors. On the left is an external ventricular drain, which is placed anatomically using the midpoint of the pupillary line and approximately 2.5 to 3 centimeters off the midline and aimed towards the nasion. One can see sort of that trajectory tangential to the skull. The EVD is hooked up to a Becker bag system. This is 0 to the patient's ear, and then the pressure of what you set the EVD to is adjusted by adjusting a gravity beer trough up and down to try to set a pressure that you want to monitor. Examples in the middle include external ventricular drains as well as ICP bolts and other monitors. These bolts can be anchored into the skull, but generally they're monitors that are placed into the brain or the intraparenchymal tissue, and they give you a pressure reading about what's going on in the brain. And on the right demonstrates different waveforms. You can see sort of the normal waveform in green showing P1, P2, and P3, various sort of troubleshooting aspects, low and high blood pressure, change that P1 wave. And you can see as you decrease your compliance, that P2 wave increases significantly until it's just a very rounded waveform without a lot of feature. So one can think of this as the waveform giving you the middle finger. That's when the brain is having a bad day with high ICPs. So what do you do when you suspect high ICPs? This is the ICP management protocol, which is, many of these have been published. This is one example of one, and we've developed one for our site, which can be found with that QR code. But generally with an ICP management protocol, the first tier or tier 0 is something that you would do for every patient walking in. Any support line staff, nurse, resident, critical care provider can do this right off the bat. It involves evaluating airway and protecting it, evaluating neurological exam, maintaining the head of bed 30 to 45 degrees, analgesia appropriate for the patient, temperature management, adequate lining of the patient, and maintaining normal hemodynamic parameters. The next tier in management, if someone has an intracranial pressure greater than 22 centimeters of water for greater than 10 minutes, is tier 1. So this involves maintaining cerebral blood pressure, maintaining normal hemodynamics, but starting to consider hypertonic saline boluses, 100 to 250 milliliters at a time, and watching for response, watching for sodium levels. Mannitol can also be evaluated as a potential option, but it can cause extra diuresis that you have to be careful for. Placing an EVD for CSF drainage is considered. Maintaining seizure prophylaxis. This indicates for 1 week for traumatic brain injury patients. And EVD to evaluate for any subclinical seizures, which can really tax the brain. If this is not successful and patients continue to have ICP elevations, the next step in the tier involves evaluating for hypercapnia and maintaining a CO2 between 32 and 35, performing neuromuscular paralysis. This idea of a MAP challenge really is more relegated to a neurocritical care setting where you have an intensive care provider that's trained and knowledgeable how to do this, but it could be a way to evaluate for someone's cerebral autoregulation and then be able to adjust blood pressure parameters as such, depending on what the autoregulation looks like at the time. And raising the cerebral blood perfusion pressure with fluid boluses and vasopressors is another idea. The last step in the management involves a pentobarbital or propofol coma. Mild hypothermia is considered. We do not really use significant hypothermia, much more in the traumatic brain injury population due to its adverse outcomes. And secondary decompressive hemicraniectomy is very much considered as an option for patients who are refractory to ICP management. What are other signs of worsening ICP or potential signs of worsening ICP that could be seen on a clinical exam? Well, you could see a decrease in GCS by greater than 1 point, pupillary asymmetry, pupillary dilatation, a new focal motor deficit or Cushing's triad, sort of hemodynamic response. So these are all clinical signs that you can observe that can oftentimes precede an ICP challenge or be at the same time and start to corroborate that you are truly dealing with an ICP issue. So how do you intervene in these situations? Well, they should be noted. The team should be notified, including the neurosurgeon and the neurocritical care provider. So some empiric hyperventilation or hypertonic saline could be used. Additional imaging to evaluate if there's a new bleed or new problem in the brain, a new stroke, and escalating the treatment appropriately using that tiered algorithm. So you should also consider that with someone having worsened neurological status without ICP issues, there could be other things going on as well. So there certainly could be edema, stroke, hemorrhage, but there could be electrolyte metabolic abnormalities, There could be sepsis, medication issues, other organ failure. These are all their considerations you have to consider and keep a wide differential when you're worried about someone declining neurologically, maybe without an ICP that corroborates. So to talk about brain trauma is one of the first neurosurgical emergencies. This is a very common problem in the U.S. and globally. About 50 to 60,000 TBI-related deaths are seen in the U.S. annually, and there's tenfold more globally. They peak in the youth due to firearms, motor vehicle collisions, and peak in the elderly due to falls. And we are seeing an increase in the absolute number of traumatic brain injuries as our population is both aging and growing. So these are various patterns of traumatic brain injury. On the left, it demonstrates epidural and subdural hematomas, which are two of the most common type, intracortical contusions, traumatic subarachnoid hemorrhage. Diffuse axonal injury you may not see on a CT scan, that's DAI. You more see that on an MRI scan, but that is something that is noted on traumatic brain injury. The dilated pupillary response and herniation event that can occur with hematoma is shown in the bottom left. Basically, you can see how expansion of a temporal hematoma can cause shifting of the brainstem, first causing compression of cranial nerves 2 and 3, resulting in dilation of the ipsilateral pupil. Well, if this sort of pressure continues, the midbrain, brainstem are all around that area, and you can get significant pressure on those, which can be non-survivable. So someone with a herniation event is a neurosurgical emergency and requires adequate treatment. Some patterns of traumatic brain injury, including subdural and epidural hematoma, are shown, and non-traumatic brain hemorrhages, which are things we'll talk about, are also shown. So these should not be mistaken for brain trauma. Non-traumatic subarachnoid hemorrhage in the top right could reflect an aneurysm rupture, and in the bottom right could reflect hypertensive hemorrhage or other things. So certainly you can get these kinds of patterns in trauma as well, but much less likely, and they should be noted whenever you're evaluating the CT scans. Various patterns of extraaxial hemorrhage are shown here, including some of their management. Generally, someone with a traumatic brain injury receives an anti-seizure prophylaxis, especially if it's a moderate to severe traumatic brain injury. This reduces early seizures within 1 week, but has no impact on long-term seizures. Initially, the study by Temkin in New England Journal looked at phenytoin, and later on, other comparative studies looked at Keppra, which has a greater safety profile. So Keppra tends to be used nationally more often. We maintain the systolic blood pressures between 110 and 140. These are particularly adopted from the ICH literature, and also various studies in traumatic brain injury literature indicate that patients outside of these windows typically have poor prognosis. So these are the numbers we try to keep. We try to maintain DVT prophylaxis early due to the high risk of DVTs for these patients, and there are additional guidelines in the Brain Trauma Foundation which can be used to guide these different options and discusses the level of evidence that supports it. So with acute epidural hematoma, generally a patient with clot thickness greater than 15 millimeters or greater than 5 millimeters of midline shift, someone that would require surgical evacuation. With a subdural hematoma, 10 millimeter thickness, 5 millimeters of midline shift, altered mental status, low GCS would require surgical treatment. Traumatic parenchymal hemorrhages typically don't always need evacuation, but if they have significant volume, greater than 50 centimeters squared, 50 centimeters cubed, or with a decrease in GCS, they would require potential evacuation to help with ICP management and reducing brain injury. Posterior fossa hemorrhages in the cerebellum are particularly troublesome because they can have obstructive hydrocephalus that forms. So these often require emergent evacuation and EVD placements depending on the size of the hemorrhage and the obstruction pattern. And with depressed skull fractures, generally with fractures that are 1 centimeter in depression, open, comminuted, contaminated, those require surgery for washout and repair. And risk of infection and CSF leak is high for those kinds of fractures that are not treated. Decompressive hemicraniectomy is a surgical procedure we do for the treatment of intracranial hemorrhages. This is sort of our last resort. This is an example of the incision and the various craniotomy that you do for it in order to do this sort of procedure, we have to make sure the patient is otherwise stabilized and doesn't have any ongoing hemodynamic issues or airway issues. A CT and CTA are important to evaluate for the cause of a hemorrhage and ensure that, sort of plan out exactly what we're going to be seeing. Informed consent is important for this, but sometimes not possible due to the emergent nature of it. Having a type and cross is important to be able to account for any blood loss that might occur during the surgery. We can temporize the patient with mannitol, hypertonic saline, Keppra, and antibiotics are important for the surgery as well. Position the patient supine, usually with the horseshoe headrest, and rapidly prep and open the scalp and remove the bone. This bone can be staved in the freezer and replanted at a secondary time. It's important to then sign out to the ICU, indicate that there's no bone flap on that patient's head, and use extra caution when repositioning the patient. Some patterns of non-traumatic hemorrhage are shown here. These are really important to recognize as you have to be very careful about the surgical route you take to treat these. So intracerebral hemorrhage or hypertensive hemorrhages are very common. They can look like intraparenchymal hemorrhages and very similar to some traumatic hemorrhages. Arteriovenous malformations sort of define an entity where you have an artery venous anastomosis without a capillary bed. These form a tangle of vessels within the brain and can have a significant risk of hemorrhage. And so an angiogram is usually used to help define this, followed by treatment with embolization and or open surgery. Radiation can also be used for non-surgical lesions. A cavernous malformation is a nodular vascular lesion with high propensity for repeat bleeding and seizures. So it doesn't always need treatment unless it becomes more symptomatic. An aneurysm is an outpouching of the blood vessels due to weakening of the wall of the blood vessel. There are various patterns that can occur with an aneurysm, saccular versus fusiform type. There are genetic reasons why patients have one type versus another. Other factors for aneurysm formation include hypertension and atherosclerotic disease, and they generally form at the junctions of the blood vessels. When they hemorrhage, they can be catastrophic due to subarachnoid hemorrhage, resulting in significant vasospasm and deficits for patients. So they're very, very dangerous. A capillary telangiectasia, shown on the upper right, is just a dilated group of vessels, usually in the pontine area, and asymptomatic and doesn't need treatment. An arteriovenous dural fistula is essentially like an AVM at the dural edge, resulting in abnormal venous drainage. With higher grade types of these with more cortical venous reflux, these become higher risk and have higher propensity for intracerebral hemorrhage and require treatment. And also note that brain tumors can hemorrhage as well, very rarely, but in the setting that they hemorrhage, they can develop significant mass effect very quickly and may need more urgent surgical treatment. Usually with brain tumors, they don't present with hemorrhage and they can be treated with cerebral, with dexamethasone or steroids to reduce cerebral edema. In the setting of hemorrhage, it becomes a different story. Penetrating brain injury is another entity that neurosurgeons treat. These can occur from a variety of injuries, including bullets, knives, shrapnel, explosions. Any kind of injury can occur. The most important thing with any penetrating injury first is the ABCs, maintaining a patient and protecting their airway, maintaining the hemodynamics. Antibiotics started earlier, important to help prevent infection. ICP management, similar to any other type of brain injury. CT and CTA imaging to identify what is the injury pattern, or is there vascular injury as well. And for surgical treatment, we do not try to take all the bullet fragments out. What we would try to do is debride the wound either at the bedside or more commonly actually in the OR to try to remove any bullet fragments, remove any bone fractures, replate the bone, repair any dural leak, and obtain hemostasis. Shown in the lower right are various effects of blast injury, which can also be seen in penetrating brain injury. But number one indicates acoustic impedance, which causes spallation. Number two is a shock bubble. Number three is a stress fracture that can, a stress shear that can cause diffuse axonal injury. Number four is cavitation. Number five, skull deformation with elastic rebound. Number six is reflection of the blast wave against the skull. Number 7 is a bobblehead effect from acceleration and deceleration from a penetrating injury. Number 8 is a blood surge from the torso, which can damage microvasculature after an injury. 9 includes air embolism from a blast injury, more related to blast to the torso. Number 10 is penetrating fragments. 11 is compound skull fracture. 12 is intracerebral hemorrhage. 13 is a contractile injury. 14 are burns, and 15 is a blast wave through the orbits. 16 is a blast wave through the nasal sinuses. All these features can occur with bullets, and the higher the caliber of the round, the more injury that can occur from the impact. Cerebrovascular injury includes injury to the blood vessels, which can oftentimes occur bluntly or sharply. For blunt injury, this is often seen in high-level blunt traumatic brain injury. We use the Biffle or Denver grading system, where grade 1 indicates a luminal injury with less than 25% of vascular stenosis. Denver Biffle 2 is a 50% injury that results in 50% vascular stenosis. Denver Biffle 3 demonstrates a cerebral aneurysm. 4 is a occlusion, and 5 is a transection. So these are various grades that are used. Typically, most injuries are grade 1 and grade 2. They can be treated with antiplatelets. Grade 3s, 4s, and 5s are treated with a combination of anticoagulation with heparin and or stenting or vessel sacrifice, depending on the injury and the collateralization of that particular patient. The higher the grade of injury, the more likelihood for stroke and morbidity, also due to the other polytrauma a patient might have. Sharp injuries of the neck typically are evaluated based on a zone grading system, with zones 1 and 3 being very difficult to manage and higher risk due to access and other neurovascular structures. These are increasingly evaluated with CTA imaging, and a lot of endovascular treatments are used for the treatment of this right now. But open surgery is still important, and the neurosurgeon can be called on to assist with the management of this from time to time. Orbital facial fractures are things that are commonly done in conjunction with facial plastics or oculoplastics. Very importantly, to consider any kind of orbital facial fracture, one has to be mindful of any CSF leaks that can occur, any clear drainage from the eyes, nose, or ears. If there's a fracture involved, this can be evaluated with the beta-2 transferrin testing. Oftentimes these can heal with some time. Lumbar drain can be used to help with the healing process. Very rarely, if those are unsuccessful, do they need surgery for repair. In terms of orbital fracture, evaluating the pupil, the vision, motion are all important. Doing force duction testing, or if the patient's awake and alert enough, having them move their own eye is really important to look for orbital entrapment. A lateral canthotomy is a procedure that can be used really by any provider. It is an eye-saving procedure, so it is really important to consider if someone has orbital injury and significant pressure on the eye. The reconstruction of orbital fracture can be done in a delayed manner, depending on the injury. Optic nerve decompression, however, if there's fragments that are pushing on the optic nerve, this should be done in a more emergent fashion and can be done through both a cranial and open procedure, depending on where that fracture is and what the patient's vision looks like. Oftentimes, the patient can have blunt injury too and have loss of vision from just the blunt injury without any impaction. So all these have to be tested for a patient, and then the imaging has to be reviewed. Frontal sinus injury, we can consider repairing the frontal sinus on the outer table if there's some cosmetic defect, or if the frontal sinus is impacted and the inner table is disrupted. This will require a surgery at some point because of the risk of frontal sinus occlusion and the formation of delayed mucocele. So it's something that neurosurgeons do. This can be done in a minimally invasive or open manner depending on the level of injury. In terms of other orbital fractures, a temporal bone fracture is something that commonly our ENT colleagues deal with, but a neurosurgeon can assist with the management as well. For the temporal bone, the Longitudinal temporal fracture is distinguished from a transverse temporal bone fracture, and the transverse type can have worse outcomes in terms of hearing. So the sort of pattern of the fracture is evaluated. For cases of mild injury to hearing in the facial nerve, one would do a delayed audiogram and some Ciprodex drops. However, if someone has significant facial nerve injury and palsy due to a temporal bone fracture, you would do serial electromyograms to look for facial nerve recovery and consider very early surgery to decompress the nerve due to the significant sensitivity of that nerve. And this is an example in the lower left of a facial nerve decompression surgery and what it looks like when you can trace out the facial nerve and try to decompress fragments from it. And for patients that have damage to the hearing bones, those can be reconstructed as well by neurotology. So those are things that we also look for and make sure we get patients seen early so that they can get that treated. Ischemic stroke is another neurosurgical emergency due to the treatment of these patients now with mechanical thrombolysis. So for any evaluation of stroke, early recognition is key. Identifying a stroke pattern, getting the appropriate labs and imaging, is getting a neurological exam, especially at a stroke scale, an NIH stroke scale. Oftentimes this can be just pulled up on your phone or a web browser to be able to complete. It's very accessible. Patients that are last known normal within 3 to 4.5 hours, if they meet criteria, would get TPA. This can often be done in the field or in a inpatient setting, depending on what patients are doing. Thrombectomy is the other method of treatment for comprehensive stroke centers, especially for large vessel occlusions. And there's some examples I have of kind of what that looks like. And after a stroke is done, your job's not done. There's still additional secondary prevention, complication avoidance, MRI scans that need to be done as well. These are some patterns of stroke that are important to recognize. So with anterior cerebral infarction, you can have motor and sensory issues, typically in the legs. Middle cerebral artery occlusion, you'd have motor and sensory deficits in the face and upper arms, as well as a field cut. Posterior cerebral infarction would cause homonymous hemianopsia and contralateral field cut. Lenticular striates within the basal ganglia would cause significant upper and lower extremity weakness and numbness. A basilar stroke, if survivable, can cause locked-in syndrome, or patients have no horizontal eye movement but can simply look up and down. The AICA, or anterior inferior cerebellar artery, and PICA, posterior inferior cerebellar artery, have various stroke patterns, which are well defined and shown on the slide. And these involve often a upper and lower extremity and a contralateral facial issue. So that's kind of whenever we're looking at a stroke pattern, if someone has a deficit in their face and a contralateral problem in their arms and legs, I think of a brainstem AICA or PICA stroke. An anterior spinal artery would cause problems with paralysis of the tongue, as well as contralateral paralysis. So for stroke, there are a variety of trials that have now expanded the type of treatments we can do for them. So the initial trials in the early 90s were the ones that got TPA approved. And then since that time, there were a number of initial thrombectomy devices that were evaluated, but really hadn't taken off until the advent of cerebral perfusion technology, which has helped us to better identify stroke earlier and to be able to identify patients that are salvageable. And these are the Mr. Clean, Escape, Extend I8, and Swift Prime stroke studies. So now the whole paradigm has shifted, and thrombectomy for these patients can truly be life-saving. We have quite a number of tools to be able to retrieve clot more effectively and identify the right patient. So the most important thing is just early recognition, getting the patients in. And the current studies that are undergoing are looking at subgroups of patients now, trying to just continue to refine the patients you select for different treatments. Shown on the CT scan is an example of a right side MCA sign, which is basically a dense sign in the MCA, suggestive of a stroke. On the CTA study, you can see absence of flow, which is circled in red. An example of a thrombectomy is shown where the the clot is actually removed, and that's what the stent retrievers now look like. They're very effective for removing these. In the upper right is a cerebral perfusion software. There's two main companies, Viz.ai and Rapid AI, that do this. But basically what you're doing when you do a CT perfusion is you're comparing the core infarct with the salvageable brain. And the difference between the two is the penumbra, or sort of what you can potentially save for a patient. Core infarct, as shown in pink here, is not going to be salvageable. It's basically is a dead brain. But the green brain is salvageable. So green minus pink indicates the amount of brain in the penumbra which you could potentially save with an intervention. And those numbers are used by stroke neurologists and neurosurgeons to then determine if a patient's a candidate for treatment. And shown in the lower right are some other devices used for removing strokes, balloon catheters to prevent distal stroke from occurring, as well as aspiration catheters, which are very effective now. Cerebral sinus thrombosis is an occlusion of the venous system, which can cause stroke and hemorrhage within the brain. These can be due to hypercoagulable symptoms, such as patients who are on oral contraceptives or have a genetic reason. These are treated with heparin. Right off the bat, heparin is a treatment, even if there's hemorrhage in the brain, because the hemorrhage is coming from the venous system, not draining blood. So you want to treat it with heparin very early and try to get a patient through that. There is a role for endovascular treatment for these, but it's not as commonly used as just heparin. An example of the sinuses is shown here, and some clinical features and imaging findings are discussed. So a dense clot sign basically is a dense cerebral suprasagittal sinus, which you can see with the blue arrow. An empty delta sign is basically a CTV study where you're not getting flow of contrast in the veins. So it's an empty delta or triangle. And on an MRI scan, you can see these the sort of pattern of thalamic sort of edema that's occurring because the brain cannot drain well. MRV studies can help demonstrate where the occlusion is coming from, and some patterns on the type of venous infarction you can get are shown, where if you have a thrombosis of internal cerebral arteries, you can get this thalamic type hemorrhage and edema pattern. If you have a thrombosis of the vena labae, you have this classic hemorrhage or edema, this flame-like hemorrhage that can occur in the posterior cerebrum. And then the thrombosis of the superior sagittal sinus causes cortical infarction and hemorrhage within the or superior convexity aspect of the brain, the parietal lobe. So these are locations that if you start seeing bleeding, they should start flagging maybe there's a sinus thrombosis going on. With cerebral infection, this is another neurosurgical emergency. So this includes meningitis, encephalitis, and cerebral abscess, these infections of different parts of the brain and different patterns. The classic triad of meningitis includes fever, stiff neck, and altered mental status, but it's not always that sensitive. So having a high degree of suspicion is really important for anyone you suspect is having a meningitis or intracranial infection. The workup is laboratory studies, including inflammatory markers, blood cultures. A lumbar puncture is okay in a patient as long as they don't have an intracranial mass that could potentially cause downward herniation. And with the lumbar puncture, we try to obtain protein glucose cell count, and we do have these PCR panels at most hospitals now that are very sensitive with picking up a lot of different types of infections. And one of the important ones, which can be commonly missed, is herpes simplex. So that's these panels are really powerful, being able to screen everything out very quickly and are very, very sensitive. The most common causes of meningitis and abscess in the brain are shown here. And the goal is to get treatment on board within 3 hours, getting some sort of culture and getting treatment on board. We would not wait for a biopsy or an LP or anything like that if someone is having meningitis and declining. You want to start treatment as soon as possible because of the potential sequelae of infection, which can include seizures and strokes, as well as empyemas and other things. So early treatment is important. We do treat with dexamethasone in the setting of infection because it does improve outcomes and reduces neurological injury. So it is something that is used. And an MRI scan is really critical to be able to identify the extent of injury. So shown are some examples on MRI scan of frontal sinus infection that has caused an epidural empyema, and something called a Pott's puffy tumor, which is sort of infection of the bone and the scalp and can cause this sort of tumor-like growth on someone's forehead. An intracerebral abscess is this classic ring-like distribution of infection with restricted diffusion inside of it. These can be mistaken for tumors, but other features that MRI hopefully point to this being an infection. Amongst the tumors, we sort of had mentioned that brain tumors typically don't present as neurosurgical emergencies unless they've hemorrhaged. But one of the types of tumors that does present as an emergency is a pituitary apoplexy. This is a pituitary adenoma that has lost its blood supply, so it can have infarction or hemorrhage, causing rapid pressure on critical neurovascular structures. So the patients present with tremendous headache, as well as vision loss and ophthalmoplegia and double vision. And it is a neurosurgical emergency to decompress these tumors, as they can have problems and permanent deficits if it's not done emergently. Once these patients are evaluated, getting pituitary labs, imaging is important. Starting patients on hydrocortisone, stress dose hydrocortisone testing is important. In surgery, emergent surgery is important. In some situations, medical management can be used. So particularly for prolactinomas, we do treat that normally with a cabergoline. But this would really involve patients that have, milder symptoms and a confirmed prolactinoma. Otherwise, surgery really is sort of the first-line therapy for this. Status epilepticus defines a patient having greater than 5 minutes of continuous seizures. It has a very high intrahospital mortality and high morbidity as well if patients can survive it. So it is very much an emergency. The first-line therapy, if you see someone having a seizure, is not to panic, but to, again, check ABCs, make sure the airway is protected, supplemental oxygen, pulse ox, making sure patient has adequate IVs. Easy things that could be ordered and done, 100 milligrams of thiamine for alcohol withdrawal type seizures, followed by D50 or glucose to treat hypoglycemic seizures, rapidly can be done and are very safe and can really be ordered by anyone. The next line for terminating a seizure is the use of Ativan, 0.1 milligrams per kilogram. You can give 1 to 2 grams at a time with a max of 4 grams. Typically, you're going to be monitoring airway. And so this is not something that you should be hesitant on. This is something you should go ahead and intervene on as long as you have control of the airway and the patient is in a safe setting, and being monitored. This is definitely something that can be administered. The next line therapy after that, which oftentimes is just ordered right off the bat anyways, is IV fosphenytoin or IV Keppra. And the doses are listed here. I'd like to just point attention to the IV Keppra. Typically, when someone's coming in with a traumatic brain injury or some other reasons, we give them a gram of Keppra to prevent seizures. And look at the dose here, 60 milligrams per kilogram, max of 4.5 grams. So you can dose someone with very high doses of IV Keppra very safely. And so this is, again, another medication that should not be, people should be shy about using. When dosed appropriately even at high doses, it can be done very safely, and is really important to terminate these seizures, again, due to the mortality and morbidity of them. The last treatment is Versed, propofol, and pentobarbital. These try to induce a coma in patients. They often require long-term monitoring to be set up. They require an airway. This is not something that you're going to order and do without the assistance of a critical care provider or a neurologist, but it's important to know that that's kind of the algorithm. A spinal cord injury is another neurosurgical emergency. This is also, unfortunately, very common. About 12,000 cases annually in the U.S., with 5,000 cases passing away from other comorbidities before they even reach the hospital. Most commonly seen in the cervical spine, and spinal cord injury is most commonly incomplete, meaning that patients do have some degree of retained motor and sensory function. The American Spinal Injury Association severity score, or the ASA grade, is a really good way to be able to discuss with other providers what the level of injury is. So an ASA A indicates a patient that is complete. They have no motor or sensory sensation below a particular level. An ASAB is someone who has some sensation but no motor strength. ASAC indicates motor strength but less than 3 out of 5 in power in 50% of those muscles below that level. And this is sacral sparing, which is really important because depending on the severity of your injury, it does predict your outcome. And ASAD is someone with greater strength. ASAE is essentially a normal person, someone who's had an injury and then comes in normal. So the easiest way to kind of remember this is that ASAA is a complete with nothing, ASAE is normal. All you really need to do is then remember ASAC, which is someone with less than 3 out of 5 strength in the muscle group, so someone who's weak with sensation, and then knowing where that level is, calling out exactly where the location of the injury is. The prediction of outcome is something patients commonly talk about, which is not something we want to give them definitive numbers about because everyone is different. But these are some general numbers when as time is appropriate for a patient, the physicians can discuss with the patient. So with an ASA, about 10 to 15% of patients can improve, generally not back to normal, but can improve to some degree. An ASAB, about 60% of patients can improve, half of those to ASAC and half to ASAD or E. And then amongst the ASAC type patients, 60% can improve. So the less severe the injury, the greater the chance of improvement. And we typically say patients have a improvement over a 6 to 12 month period of time. So it's a very slow process. Shown on the right are various areas that we evaluate for patients with spinal cord injury. Proprioception, vibration are shown in the posterior columns in purple, and sensation is in the anterolateral and spinothalamic column shown in blue, and the motor area is the cortical spinal tract shown in orange. So these, the spinal cord has multiple pathways, but in a day-to-day clinical exam, these are the pathways that we can actually evaluate. And the dermatome is a great way to help identify where the level of injury is. So the C6 to T1 distribution is in the arm. You can remember C6 is your 6-shooter or your gun shooter. T4 is the nipple line. T10 is the umbilicus. L1 is the groin. And then L4 distribution is the patella. So if you're trying to figure out what muscle is innervated by C5, you're like, okay, that's the bicep. It's higher than C6, that's C5. So biceps probably mostly C5, which it is. So you can use these different dermatomal maps to help identify which nerves innervate which dermatomes and muscles. And as you're getting the patient to do various neurological tests, you can help to identify where the level of injury is and as it changes day by day. So the management for spinal cord injury, again, ABCs, stabilizing the patient, maintaining airway, breathing, circulation, getting CT imaging, bracing the patient. Very importantly, we really only have one medical management for the treatment of spinal cord injury, and that's MAP augmentation or increasing mean arterial blood pressures greater than 85 millimeters of mercury, done usually for a period of 3 to 7 days. That's really about the only treatment medically we have for it. We don't really have stem cells or anything else that we know clinically works reliably. Many things have been tried in a research capacity, but really the MAP augmentation is the only thing that we know has a significant role right now. And surgery within 24 hours to decompress the spine is really important. And we'll talk about some indications that can help identify those kinds of patients. And rehabilitation afterwards is really important. I put the Christopher Reeve Foundation on here because this is a really good resource for patients to learn more about living with a spinal cord injury. And it's something, as they have lots of questions, we can point them to right in the hospital and their families as well, so they can start to learn about what this sort of means. With surgery or stabilization, what we're trying to do is prevent additional injury to the spinal cord and stabilize the spine so that it can be protected for future activities. So with spine bracing, we use immobilization. There's not really a perfect device. Bracing like a C-collar or brace is used to help stabilize the spine. We use these braces to give us some time so we can evaluate the patient, but for someone with an unstable spine, these are not options. This is just not even a temporary fix. They're not able to completely stabilize the spine. We can also use them to help with healing if someone's had surgery, and we can use them for pain control by helping to offload the muscles in the spine. It can help patients with pain without giving them pain medications. So those are various reasons we'd use a brace. For spine surgery, the indications for surgery, there's many classifications that try to look at which types of injury patterns need surgery and which don't. The goal is to just to decompress the spine elements, protect them against further injury, and stabilize things. So some general surgical indications are 3-column injuries. This comes down to the Denis classification, where the the spine was divided into 3 columns, anterior, middle, and posterior. And if you have 2 out of these 3 that are disrupted, more likely you need surgery. Patients with neurological deficits, where there's something impinging on the spinal cord, they're more likely to need surgery. Patients with angulation deformity or canal compromise or significant loss of height of the vertebrae, those are other indications for surgery. The AO spine classification shown on the right is another way to look at patients that may need surgery. The type A fractures, or these compression injuries, typically going down to even the incomplete burst type A3 fracture, those can be managed most often with a brace. Whereas once you start getting into the complete burst fractures and you start having impingement of the spinal canal with a fragment, then you might start considering surgery. The type B and C injuries, the distraction and translation injuries, these oftentimes need surgery. And this sort of classification is shown here for the cervical spine, but also there's an equivalent one for the thoracic and lumbar spine. These are some examples of spine surgery: an ACDF, shown with plating and screws from the front, a posterior cervical fusion, posterior cervical laminectomy to decompress the spine. Other examples of spine surgery include a cervical corpectomy, a posterior lumbar fusion, and the lumbar corpectomy, various examples of it. Some spinal cord injury patterns that are important to recognize. Transverse cord lesion basically takes out all the motor and sensory issues. So you see the blue, red, and green are all disrupted. Central cord syndrome involves an injury to the center of the spine, preferentially injuring the hands over the feet. The patients to complain of a cape-like distribution of numbness and tingling in their hands, weakness in their grip. This can be the patient could be wide awake talking to you and complain about a little bit of weakness and numbness in their hands. This is a spinal cord injury, and it should be treated as any kind of severe spinal cord injury, with monitoring hemodynamics and considering whether surgical decompression is necessary. It's not a benign thing. Posterior cord syndrome or anterior cord syndrome involved injury to the blood vessels of the spinal cord and result in various injury patterns depending on which tracts are involved. Brown-Séquard syndrome is a hemitransection of the spine, where you can have a loss of sensation ipsilaterally just above the lesion, impaired proprioception ipsilaterally on the side of the lesion, and then impaired pain and temperature on the contralateral side. So patients might start complaining of some vague asymmetries in their exam, and that should flag that a Brown-Séquard syndrome has happened, usually from a bullet or a knife wound, but can also occur from a needle or in pain injections. I've seen that as well. So these are things to kind of monitor on the exam for that. Cervical myelopathy is a injury pattern of the cervical spine, especially as our population is getting older. We're seeing more of these patients arrive to the ER, oftentimes not knowing that they had something wrong with them. And so what's happening is a compression of the cervical spine, resulting in disruption of blood flow and oxygenation of the spine. And the reason that's happening is we have degeneration of the spine occurring, where patients have loss of disc osteophyte complexes, hypertrophy of the ligament, calcification of the ligament, all these different things that are just causing the spine to collapse down and put more pressure on the spinal cord. And it's happening over a period of months, resulting in inability for the spinal cord to work. These patients can all of a sudden deteriorate, or they can have a minor fall and they can come into the hospital with significant spinal cord injury from just a minor fall. So this is a neurosurgical emergency, because if patients are having ongoing pressure on the spinal cord and you don't decompress or stabilize that, they can have further decline, and not recover as well. So it is something that we commonly see and intervene on if someone's not recovering well. So conus medullaris syndrome is another entity that describes compression of the conus medullaris at L1, and this is similar to cauda-equina, but it has more bilateral features. Some various spine injury patterns are shown here. You can see atlanto-occipital dislocation, where you have significant spacing of the occipital condyle and C1 lateral mass. A C1 fracture shown here within the anterior and posterior arch. A C2 dens fracture, you can see across the dens. Jump facets, where the cervical spine has translocated and compressed the spinal cord. A Hangman's fracture, which is a C2 fracture in the lower left. Compression fracture right next to it, and a burst fracture. And the burst fracture, or an A4 type fracture, is when the fragment is pushing within the spinal canal and the posterior wall is disrupted. A chance fracture involves a fracture going across the pedicle, and a fracture dislocation sort of needs no explanation. It just looks like a very bad fracture. Spine infections are important neurosurgical emergencies due to the significant potential for neurological deficits. So these can be divided into pyogenic, bacterial type, and non-pyogenic types. And vertebral osteomyelitis describes infection of the bone. Discitis describes infection of the disc space. Septic arthritis describes infection of the joint. The bacteria are the most common causes that these occur, and typically patients have some risk factor: diabetes, immune compromise, IV drug use. They can certainly get it from not having any medical issues as well, but typically there is some sort of risk factor that can be asked about. Blood cultures are very sensitive for detecting the type of bug, so that definitely needs to be drawn as early as possible. Antibiotics need to be started as early as possible. We use surgical intervention for patients that have compressive epidural infection, neurological deficits, or they're declining. Those are sort of the reasons we choose to do surgery. Otherwise, if someone is relatively asymptomatic, you can treat them with antibiotics alone and monitor them very closely. Here's some MRI examples of spine infection, including a Pott's tumor, which is a tuberculosis type infection, which spares the disc space, which is a very classic type of infection pattern. We don't see it very common in the US, but it is one to know about. Peripheral nerve injury is a neurosurgical emergency as well. Oftentimes these can be underdiagnosed, both in the upper and lower extremity. For patients who have a sharp transection, sort of a knife or penetrating injury that causes a deficit, early exploration is important to help with improved long-term outcome. With most injuries, however, they are stretch injuries, and we typically wait to give the nerve time to heal, about 3 months, and then test with EMGs. And then if the nerve has not healed, there's various treatment options, including neurolysis, where you try to break up scar tissue, nerve augmentation, where you take good nerves and attach it to nerves that are unhealthy to try to get a little bit more function out of them, or there are nerve and tendon transfers to reanimate nerves that have deficits. There's various classification injuries of the nerves. The Sunderland classification is one of them. Basically, as you go from grade 1 to 5, you have worsening injury, greater transection of the nerve. The peripheral nerves can regenerate. So when they're connected and there's a stretch injury or you have some internal injury, if you just leave the outer structure alone, the nerve will regenerate and heal with time. It grows about 1 millimeter a day. The worse the injury, the more you have to sort of intervene early to get this recovery to occur. And here's an example of a patient that had a transection at the peroneal nerve, where the nerves that were severed were identified and sutured back together to improve recovery. Brachial plexus is sort of the bane of anybody in medicine to sort of understand, but it's really important because of all the different nerves that come off of it and how injury patterns can affect the arm. So a nice diagram is shown here on the right, which discusses the various types of injuries and what you might experience. So an axillary nerve injury from, say, a fractured humeral neck would result in weakness and numbness of the deltoid. A musculocutaneous nerve would cause a deficit in the bicep reflex and arm flexion and weakness. A radial nerve injury, which can occur from a mid-shaft humeral fracture, would cause a wrist drop and a weakness in wrist extension. Medial nerve injury from a fracture of the supracondylar part of the humerus would result in weakness in the hands. And a ulnar injury from a fall on the elbow would cause weakness of the ring finger and pinky and other components of the hands. So these are really technical and difficult to identify, but I think the thing to keep in mind with this is when these patients are getting evaluated, we're getting images of the brain and spine, and we're able to see if someone has an injury to the spine often. But if they're recovering and they're having persistent weakness in the arms or legs that doesn't fit with the brain and CT imaging of the spine, something should ring a bell that perhaps is a peripheral nerve injury, and it requires a little bit more digging, pulling out the brachial plexus chart to figure out, is there a particular nerve that could be injured and we're missing something else. So it's more to just create a high degree of suspicion to kind of know that this can also occur with polytrauma. And the same thing can occur with the lumbar plexus. If someone's got normal spine imaging, but they've got weakness in their leg, not painful weakness, but true weakness, perhaps they have injury or stretching of the lumbar plexus. Maybe they have pelvic trauma. Maybe they have orthopedic trauma. So this is also something to keep in mind. So for the lumbar plexus, we've got the obturator nerve, femoral nerve, common peroneal nerve, tibial superior and inferior gluteal nerves, which are shown here, and the various locations that an injury can kind of cause. A shunt malfunction is another neurosurgical emergency. This involves patients with shunts, obviously, but anyone who comes in with a shunt should have a high degree of suspicion that perhaps they are having a shunt malfunction. The symptoms of this can mimic any other kind of illness as well. So it's important to get a good history, figure out when the shunt was placed, how many revisions they've had, what kind of symptoms did they have when they had prior shunt malfunctions. If their patient that is nonverbal, perhaps getting feedback from caregivers as to what the normal level of function is for the patient. And also looking at infection. So oftentimes patients presenting with UTIs or upper respiratory tract infections can reflect a shunt malfunction. So it's important to look for what else could be going on. We typically work this up with a CT scan and a shunt series to look for the hydrocephalus, as well as looking at a disconnection, which could kind of explain that. To look for shunt infection, you can do a lumbar puncture or a shunt tap. We prefer trying not to do a shunt tap, just because if the shunt is working well, you don't want to seed it with an infection or damage it. So we try to avoid doing shunt taps unless absolutely necessary. And most shunt problems occur at the proximal end of the catheter coming out of the brain or the valve that get occluded. And unfortunately, the shunt failure rate is very high, 30 to 50% in 2 to 3 years. So this is a very difficult problem that unfortunately happens too commonly. Sports injuries are common things that we get asked about, and I put them on here just to sort of discuss it a little bit. So we get asked a lot about sports concussions, patients coming in, maybe they don't have a lot of injury to the brain seen on a CT scan, but they've had a concussion. How do you sort of return them to play or advise them on returning to their normal activities? There are not very good concussion guidelines that exist, or even classifications of concussion. Clinical exam has its limitations. Various types of softwares or testing systems exist that all have pros and cons. I like this old classification system from the AAN discussing grade 1, 2, and 3, because it basically starts to think about concussion on a scale, on a sort of a grade of severity. Patients coming in with very mild issues, they really recovered during right after the concussion occurred. They probably can return to their activities or return to play very quickly. Versus patients that had a loss of consciousness, they're still having persistent headaches, nausea, memory issues. Those are patients that should not be going back to their normal activities or to sports that can risk them. So when you start thinking about patients along the spectrum, you can start to think about, where does a particular patient fall? Are they asymptomatic? Or are they very symptomatic? And generally, the brain does heal with the first-time concussion. It will heal well if you give it time in most patients. You want to avoid a secondary concussion which taxes the brain. So that's the whole goal of concussion return to play management. And neuropraxia is another type of kind of sports injury we get. A stinger is sometimes what they're called. You can get this in the peripheral nerves. You can get this in the spinal cord. Basically, the nerves have been stretched beyond a point that they should have, and the patients have weakness, numbness, tingling from that. The treatment is rest. The treatment is trying to avoid stretching of that area again, giving the body time to heal. One of the last topics I want to talk about was anticoagulation and antiplatelet reversal. This is a common thing that comes up for neurosurgeons, especially modern times where patients are on a lot of medications for various indications. We have a variety of different reversal methods that exist now. Thankfully, they're not always perfect, but we do have many more options than we previously had before. So the coagulation cascade is shown here, where you can see where the vitamin K agonists are involved, where the factor 10 inhibitors are involved, and where the direct thrombin inhibitors are involved. And various reversal agents are shown, vitamin K and concentrated 4-factor K-centra for the reversal of warfarin, protamine for heparin, praxibine for dabigatran, and then Andexa, as well as K-centra for the factor 10 inhibitors. So depending on what is on at a hospital's formulary, you have a lot of different options that exist. Reversal of antiplatelets is difficult. Giving platelets, giving DDAVP or other medications is very challenging to reverse antiplatelets like Plavix. And the other thing that's often used in a trauma setting is TXA, or tranexamic acid. That is another treatment that can be used very early on with head and spinal cord and polytrauma type injuries to reduce bleeding. Thank you very much for your time and attention. And if you would like to see some of the protocols that discuss the ICP management, you can follow the QR code shown here, as well as if you'd like to see the recording of this lecture and other lectures, the QR code on the right will direct you to that. Thanks again.